Hi everyone, my name is Will Etchells and thank you for tuning into my presentation. For this case study, we students were tasked with finding a healthcare related journal or news article and related to concepts learned in Chapter 7, Medicare Prospective Payment Systems of Harrington's textbook. Hi everyone, my name is Will Etchells and thank you for tuning into my presentation. For this case study, we students were tasked with finding a healthcare related journal or news article and related to concepts learned in Chapter 7, Medicare Prospective Payment Systems of Harrington's textbook. To better help the viewer understand the article and topics related to the text that I will be discussing, I would like to give a quick background of the history of prospective payment systems. The traditional payment system before 1982 was a retrospective cost-based reimbursement environment. This meant that the provider, such as a hospital, was paid interim payments throughout the fiscal year, and at the end of the year, the hospital would submit a cost report. The payments made the year were reconciled with the costs allowed, creating a cost-to-charge dynamic. This caused an increase in the annual price for the Medicare program to increase from $3 billion to $37 billion annually, and Congress made a decision to create a prospective payment system, or PPS, to better control costs. The PPS is designed as a per-case reimbursement program in which Medicare pays a hospital a flat rate per case of inpatient care. With that being said, let's dive into the article. The article that I found to become my focal point for this case was an article written by Rita Rubin titled "How Value-Based Medicare Payments Exacerbate Healthcare Disparities." The article discusses how in 2015, the government passed the Medicare Access and Chip Reauthorization Act, or MACRA, in which physicians are paid based on the quality of the care provided to patients rather than the quantity. Rita Rubin discusses how this sounds like a good idea, but the tools implemented for how to evaluate the quality of healthcare are severely lacking, and the measurements fail to account for differences in patients' socioeconomic and overall health status. I found this portion of the article to be very interesting because it made me think back to my readings in Chapter 7, in which Harrington discusses the prospective payment system and how it is designed to reimburse a hospital based on a diagnosis-related group, or DRG, which is a way to group together patients based on the diagnosis given at the time of discharge. Rita continues the article by discussing how data like a person's socioeconomic and health status not being taken into account is detrimental to healthcare providers that care for lower income and more sick patients. She discusses that the scores for the quality of care lean favorably to providers who care for better educated, higher income, and less complex patients, and how bonuses for organizations that score higher in quality of care are offset by the practices being penalized for scoring lower or not submitting data in terms of quality of care. She even goes as far to state that Medicare's pay-for-performance scheme is a zero-sum game and describes the facilities providing care to higher income patients as winners and facilities providing the low-income patients as losers. What Rita is describing in the article here really made me raise an eyebrow because it made me remember back to my readings in Chapter 7's section of a disproportionate share adjustment, or DHS. A disproportionate share adjustment is if a hospital treats a high percentage of low-income patients, it will receive a percentage of add-on payment that will be applied to the DRG adjusted base payment rate, according to Harrington in Chapter 7. There are statutory formulas that are in place to help identify hospitals that would fit into the DSH category, which take into account factors like Medicare inpatient days for patients eligible for Medicare Part A, Medicare Advantage, and Supplemental Security Income, or SSI, as well as total inpatient days for patients eligible for Medicare but not Medicare Part A, and this is all according to Casto and Forstall in 2013. There are two ways a hospital can qualify to become a DHS facility or DSH facility, with the first being that if they exceed 15% of the formulas just mentioned, and the second being is if the hospital is set in an urban area and can prove that more than 30% of patients' revenues come from government subsidies. I understand that Rita is talking about the quality of care being the problem, but I'm curious as to why the DRGs, as well as the DHS's systems, are in place if they seem to not be working and are driving hospitals to want to care for more well off patients. Rita discusses how the cycle continues because incentives are so stacked that that it is incentivizing hospitals to cherry pick patient care to patients who are more likely to try to stay healthy. Rita believes without taking into account a patient's socioeconomic status, this cycle will persist. An attempt for change is in place, but Rita believes that this is not a dramatic change. This change is in the form of merit-based incentive payment systems, or MIPS. MIPS differs from the value-based payment system in the form that it allows hospitals to choose the quality measures that it will be assessed on. Michael McWilliams, a professor of healthcare policy at Harvard Medical School, stated in the article that essentially we are going from providers knowing the test questions in advance to providers being able to pick the test questions, and I couldn't agree more with this statement. I feel that it is just giving more incentive to hospitals to play into the game I discussed earlier with winners and losers, and allows for them to control their own narrative. A change in the form of accounting for case mix is what Rita believes to be the top priority. She believes that case mix in the form of a patient's socioeconomic status and medical complexity could minimize the effects of that pay for performance has caused in the healthcare system. I personally felt that this is very difficult to measure, and an example I thought of was something along the lines of two cancer patients. How is it possible to measure which patient is more sick than the other, and what diseases are worse than others in the government's eyes to determine just how sick a patient is? Rita proposes in the article that another way to approach minimizing disparities that are currently in place is to compare apples to apples and oranges to oranges. She states that in a study in 2015, it was introduced the idea of Medicare rewarding facilities that are providing the best care to low-income patients and also rewarding facilities that are providing the best care to high-income patients. The article concludes by stating that the merit-based incentive payment system will be adjusting payments based on the number of patients that are eligible for Medicare, which can be an indication for low socioeconomic status. Rita believes that this is a start to combating the current system in place, but there are larger problems as a whole, such as social justice and income inequality, that need to be addressed directly, not indirectly through public policy. Overall, I have to say that I enjoyed this case study very much, and the article gave me great insight into how medical payment systems work and created deep thought and critical thinking when relating it to Chapter 7 of our text. This concludes my presentation, and I thank you for tuning in.